Good morning, everyone. Today is my great pleasure to introduce our speaker, Leslie Macho, who has a nursing degree from the University of North Dakota and the nurse practitioner degree from the University of Minnesota. And she's been involved in the care of cardiac patients for over 30 years in various roles, including being actually there in the OR and assisting with left ventricular assist device implantation, also congenital heart disease, and now palliative care medicine. She joined Abbott in 2015 and has been involved in the care and holistic approach to a cardiac patient since then. She's been playing a big role in specifically heart failure patients, but also other cardiac patients, and now actually has a clinic where she sees all different patients, including adult congenitals. So today she'll talk to us about palliative care medicine, especially with a focus on a cardiology patient. Welcome, and thank you so much for being with us.
Thank you. Thank you for that introduction, Kasha. Today what I'm going to be talking about is when, where, can you hear me okay? Okay. When, how, and why to refer a patient to the palliative medicine clinic, or when to see them in the hospital. I think the first thing we have to understand is how palliative medicine is different from the end-of-life support of hospice care. Palliative medicine is a holistic approach provided throughout a patient's life in conjunction with active treatments such as inotropes, chemotherapies, medications. It focuses on treating symptoms, emotional and spiritual concerns, and helps patients and families understand illness and treatment choices. Palliative medicine has a team approach with physicians, social workers, advanced practice nurses, and spiritual care. It's involved with symptom management. But what are the statistics that say why we should have palliative medicine focus either in the outpatient or in the hospital? Well, in a study of over 2,000 patients, it did reveal in metastatic cancer that those individuals, of every 8 patients, 1 less patient was diagnosed with depression. In that same study, it also revealed that the average survival was up about 3 months for patients that received the palliative arm of therapy. It also showed in different studies that it saves money. It averages about $3,000 plus for patients, and this was in the United States and then across in Europe, in Ireland. One of the other things it shows is that the average hospital stay is down about 13% for those in the hospital that receive palliative medicine. When you kind of look at those statistics, they all sound like a good thing for patients. Key takeaways from statistics: the average life expectancy 3 months longer in over 2,000 patient study. Patient mental and spiritual health is generally improved, and we're saving time and money during the hospitalization. So why? Why is a question that I get quite often. Why would I ever choose to go into palliative medicine? Why would you think it's important? I think those whys also add to personal experiences for me and what I could have felt was helpful when I was having difficulties with family members that were passing. I lost both of my in-laws at age 50 years old of cancer within a year of each other. I'm in my 20s at this time with my husband. I'm pregnant. I have a 1-year-old child. And I'm trying to navigate a system that I've never gone through before. What I found out through this process is that I really didn't know what to do. I didn't have people that talked to me about, this might be the prognosis, that you should get ready for this. We didn't have people that guided us to say, do you have these affairs in order to be ready? It wasn't until we actually ended up with hospice team support that those balls started rolling. But I really hadn't planned for anything up until that time. The other thing that really changed my thought process through the years is when I was part of the REMATCH trial. We had started REMATCH in the late 1990s, and we are now starting to enroll our first patients. And unfortunately, the first 2 pumps that I had placed passed away. They were in the animal lab. They were cows, And when you're thinking about it, when you're doing a device as this size, a 2.5-pound pump that's not only in the chest but in the abdominal cavity, you would want your surgeon to be doing it probably on something else for the very first patients that we've done. When we actually had our first patient that we did, that first patient passed. It was very difficult for me to go into my next patient, because I was doing a pre-ops and I was in the operating room with these patients, to sit down with him and talk about this device. He said to me, "Leslie, I don't need to live another day. I have had the most blessed life that anyone can have." He's a farmer, the salt of the earth, and he said, "The only reason that I am doing this is to give back. The reason that I am having this device implanted in me is I want to extend technology. I want to give other people a chance. I'm a farmer, I like machines, I will do this. But you have to promise me that you're going to follow me from the beginning to the end. Meaning that when you're with me in the beginning, that you'll follow my course the entire time, and when it is my time to pass with this machine, that you will make sure that if I don't have good quality of life, that it will stop, and that you will take care of my wife and help her along the way." I knew with a study that I will follow him from beginning to end, but I took that to heart about how important it is not only in the living process and helping someone get better, but also to follow them and make sure the end of life is also peaceful, comfortable. Let's do a couple case studies that I've had recently. Jim is a retired physician in the hospital. He's had end-stage heart failure, prostate cancer, and chronic back pain. He is insistent on deactivating his pacemaker. The medical team consults palliative medicine to discuss goals of care. They say he just must be depressed. Well, when I have a conversation with Jim, he tells me his quality of life is extremely poor, that it is his right to deactivate his pacemaker. We discuss his symptoms and what we can do to increase quality of life. Really, what can we do to make this better? And I discuss with him, even if I deactivate your pacemaker, the individual almost always has a minimal junction escape rhythm of 30 to 60. And most always, people actually have an underlying atrial fib, or they have a sinus rhythm. They might just have pauses on occasion. I recommend leaving it active. Even with the recommendations, he said he wants it discontinued because the quality that he has is not what he's looking for. Well, it is legally in any patient's right to deactivate any artificial equipment or sustenance. These are including items such as ventilators, LVADs, pacemakers, medications, ICDs, tube feedings. I think Chuck Gornick says it best when I'm in rooms. He'll say, "I am not in the position to prolong life without quality or add suffering. These devices are meant for good quality of life." And so these are things that we should take a look at and really sit. It takes time really to dive through a process like this with a patient. We ended up deciding to deactivate his pacemaker. He had an underlying rhythm of atrial fib in the 60s. But we also made plans with the family. When somebody's talking like this, they're asking for help. How do I get support in my home? How do I get the help that I need? So what we ended up doing is getting, for him, additional support of hospice care in the home. This, again, is more of an end-of-life process, but with our team, what we ended up doing is going through goals of care to get there. Anytime we are deactivating a pacemaker, a medical professional does need to be there, either an advanced practice nurse or physician. This is not the case, of course, for ICDs. When, again, should we consult? It's when we're looking for assisting families with advanced care planning with the patient, and we often have a potentially life-limiting time frame. It can be weeks, it can be months, it can be years. We're looking that they have great symptom needs. We're addressing home support and accessing service, and we're also addressing spiritual and mental health concerns. Another case is we've got Mr. Jones. He's a 73-year-old patient. You follow him in clinic for amyloidosis, but now he returns to you after having a recent hospitalization. And during this time, he's had end-stage heart failure symptoms related to his hereditary AATR, amyloidosis. he says, I know things don't look good. I don't want to die a miserable or painful death, but I don't want to roll over and not do anything, and I want to continue to fight. So what are things that we can do to help him with his quality of life while he's undergoing oral transthyretin treatment for his amyloidosis? Well, we know that the TTR is broken down in the liver, that it's binding the amyloid fibers. I know most of the cardiac people here know this in the room. And that it deposits in the heart, the nerves, it can deposit in the intestines. Well, the symptoms that Mr. Jones is having, he's having both heart and peripheral neuropathy symptoms. He's now having neuropathic pain and loss of balance. He's having orthostatic hypotension. He does have preserved heart, he's got heart failure with a preserved ejection fraction, but he's also having now new symptoms, increased dyspnea, activity loss. He's not tolerating diuretics, and he's having signs of renal failure. Why again? We're consulted by cardiology to focus on symptoms, treatment, and discuss prognosis with his family. In a family conference, a lot of times if you ever see me in the clinic, there is, before COVID, and now even with COVID, a lot of times will have 4 or 5 family members with me. And a lot of times an additional 2 to 3 on the phone. I find that when I'm talking about something like this, the more family members we can get, the better understanding everyone has together. The mean survival with cardiac amyloidosis is about 13 months. But when an individual is diagnosed with congestive heart failure, that mean goes down to approximately 6 months. Now we're adding additional therapies. We have new treatments that are out there, but do some of these new oral treatments make a difference? What the studies are showing that it's hopefully increasing quality of life, but it's not increasing quantity, meaning that we're trying to stop those symptoms, but we're not increasing time. Now the study's just out. I never try to give away hope for people. Hopefully we will get more time. We don't know for sure. It's just starting, but the studies are showing this. It's about giving realistic information. Then going on what his hopes are, what he's wanting. He's got a grandson that's graduating here in the spring, so talking about how do we try to get him there. We also just discussed genetic testing for the children, and here at MHI, that testing is actually done free of charge for family members. He also has a CRRTD device that's got a battery life that's only 6 to 9 months left. So we discussed, do we replace it with the time frame that we're looking at? What we ended up deciding is every 2 months to a month when he comes into clinic that we'll reassess. How is he doing? Is he looking like things are going well or not? We ended up deciding not to replace the device at this time, but we did deactivate the ICD component. We also sent him to dispensary for medical marijuana because he was unable to tolerate gabapentin, ibuprofen, narcotics with his renal failure. He was having tremors with gabapentin. And we also did starting to get supplies in the home, medical equipment, increased nursing services. And this is all done in conjunction with his primary care physician in cardiology. And we also just started discussing when hospice care is appropriate when you're looking at a shorter 6-month time frame. Why, again, are we thinking about referring? We're trying to start goals of care conversations to assist with planning before we lose that opportunity. We know in the United States that the leading causes of death haven't changed too much. COVID year might have changed the output this year. But heart disease, cancer, accidents, stroke, COPD, what we can look at with most of those is that most of them have a long trajectory. It's not something that happens, I'm going to pass overnight. The American Cancer Society is recommending all patients with advanced cancer receive palliative care, and we're now starting to do advanced disease processes, other ones that palliative care is being recommended more frequently. So why are so many individuals not accessing resources that are available? And part of it's not knowing how to explain what palliative medicine is for a provider. And how do you bring up that referral? What I usually tell them is palliative medicine is a supportive service, that it is here to address symptoms, it is helping to prolong life with quality. It is not hospice care, but it's helping navigate an illness for a family and walk through that process. Another case study is we've got an 82-year-old gentleman with progressive vascular dementia. He's had a small stroke, he's had heart failure, and an EF of about 35%, peripheral vascular disease and neuropathy. It's probably somebody we see in clinic every day. He's coming into the clinic for the palliative care clinic at the request of his daughter, who's a nurse. Dad's becoming a lot more forgetful. I'd like to discuss goals of care with him before he can't assist us. We discuss his hopes and cares. He wants to continue fishing as long as possible, and he really never wants to be in a care facility. I think we hear that every day. I really never want to be in a care facility. So we started addressing increased needs and how we would get those needs for him as his condition declined, for him and his family. We also started addressing his symptoms. We started him on gabapentin for neuropathy. I also encouraged him to see a neurologist. Actually, here at the clinic, we do have a neurone clinic. One of the new things that they have is they have an area now where if you have people with early on-stage dementia, that they have memory training programs, and they also have neurologists who are helping prescribe prescriptions like Abilify and things, and when they're appropriate for people with memory loss. We also completed a healthcare directive that's dementia specific. It really goes through, if I'm losing my memory at these points in time, what would I want? Dementia is the highest rising illness that we're seeing on our end-of-life trajectory. In fact, it really wasn't even on the top 10 list probably even 15, 20 years ago. And the reason that we're seeing it getting so much higher is that we're able to have so many more life-sustaining therapies, such as stents, bypass surgeries. So vascular dementia now is able to come to the forefront. This is one of my favorite patients. It's a 19-year-old Ben, referred with end-stage single ventricle congenital heart disease in the clinic. He's had multiple second opinions that there's no additional surgery options. He has an oxygenation saturations in the 70s. He's cyanotic and blue, but he's mentally intact and he walks into clinic. When his mother first called me, she's in absolute distress. You know, I've told he's got maybe days to weeks to live. What am I going to do? I'm not ready for hospice. He's walking around. So when I come into clinic, we assess his functional capacity. You know, congenital heart failure is a new field now. We have so many people now that are living way beyond their years, and we don't know what they can do. And people that were expected to die at 9 months are now 22, 23 that are walking into clinic when I'm seeing them. But they have a lot of symptom burden. When we started talking, it was pretty clear that he was able to do functional tasks. So what we ended up doing is sitting down and talking about what his goals were. You know, you're 19. His goals were to be around people as much as possible. He'd been pretty isolated with his disease. He was hoping that he would maybe have a girlfriend someday. And he was also hoping that he would be able to have family around him more, meaning travel with them if he could, get out more, because he'd been so scared that he'd not been living and doing those things. Because he was able to walk into clinic, and actually I'm seeing him with oxygenation saturations in the 70 percentile range, and he's mentally clear, we start discussing what he can do. What can you do? We ended up finding his love was also reading books. So together with his mother, we helped him find a volunteering position at the library. He started volunteering at the congenital adult clinic. He started taking classes at Augsburg. So he was taking 1 class a semester. So for 2 years he was in my care. He started having more decline. His now SATs were in the 60s. We did add oxygen for him that he started wearing. At first in the 70s, I started him at night and then during the day. When you've got a total free-for-all, oxygen isn't going to help that much, but it did help him a little bit to feel better. We also had him going into ENT for chronic sinus infections, really worked on his calorie intake and how to get him to a level where he was maintaining weight. And really we ended up with his goals of care being, when it was his time to pass, the one thing he had asked is to have his sister and his parents around him. And he did. This is a study, or this is a patient from clinic that I think, Kasha, I think you know this woman. We have a 30-year-old female. She has 3 children. Severe end-stage heart failure. She's not a candidate for LVAD therapy or hospice. Now what do I do? So we discussed her goals of care, and it's very clear that her goals are to live as long as possible to be with her 3 children. She is on milrinone therapy. She is getting a paracentesis every week, and her ejection fraction is around 5%. And it looks like it's probably related to both maybe substance abuse, but it looked like it was primarily related to postpartum cardiomyopathy. It's always difficult. We think that there are services for everyone. We are very fortunate within Allina because our hospice care, our palliative medicine support is so much stronger than if I were in North Dakota, in South Dakota, if I were in the Hennepin County system. She actually, when people get medical assistance, they actually put it in pots of different hospitals. You're assigned to different systems, and they do that to spread how we keep systems afloat without one system having all of the patients in that pool. Hers was through Hennepin County, and so we were unable to get her hospice care. They would not take a patient with inotrope therapy and hospice, where Allina will. So what we did is Dr. Samara and I saw her monthly when she would show up in the clinic, and she was able to eventually get aspiradrine so that she wasn't coming in weekly, and so we had her tap her abdominal fluid. And we were able to manage her in between clinic visits. She did have an arrest in between that time. I think Kasha was in the hospital with her that day. She survived, did well, went home for another 3 months. I think part of you are probably asking me, Leslie, why wasn't she a do not resuscitate? There are times when people have choices, and her choice was clearly to live as long as possible with her 3 children. I can recommend do not resuscitate, but I have to look at what her goals were, and that's what hers were. We ended up having her come back into the hospital where she ended up passing, but she lived an extra, I think it was 9 to 12 months with the support of the palliative medicine service. I've got an 89-year-old female on hospice, and she comes into the emergency room. She's got end-stage heart failure. The patient's daughter panicked and called 911 instead of the hospice team. The emergency room physician calls me down, and after he's asked the daughter, would you like everything done then? That's kind of a difficult statement because as a family member, you know, she said, I was thinking, well, do you think my mom's only worth 50% care? Do I get a discount for half care? She said she laughed when she was talking to me, but words matter when we're talking to people. So when I sat with her and I said, why did you bring him in, your mother in today? What were you hoping for? And she said, my mother wasn't supposed to die today. I promised my brother he would be able to see her before she passed. So we didn't do additional x-rays, lab draws. We gave her some fluid. And the patient had some time so that she was able to go back home with hospice until her son arrived and passed. So these are times why consult? Because spending, you know, a ton of money and causing her trauma with a lot of workup, that was the ball was starting to roll, to stop that and really listen to what somebody was asking for. Often when I'm visiting with people, it's about realistic hope or true information. It's that no one wants to squander away hope for anyone, but false hope can squander someone's precious time. So a lot of times people are asking for things that aren't possible. How do we gently talk about what is possible and be realistic about that with family? Some of the good news in the year 2021 is that I have many treatments to offer you. But the bad news, unfortunately, is mortality is still 100%. Palliative medicine during COVID, what we've ended up finding is a lot of times we have been the consistent face for family members. That when we've had intensivists that have been working and are only there one in every 3 days, that the turnaround is so great that it's a consistent face for family members when you've got somebody critically ill that's been in the hospital for over 30 days on ECMO support, on the ventilator, and how do we bridge that gap for family? In fact, I just got a call from a family member who had been in the hospital for over 30-some days, and he was on ECMO. He was on ECMO, and then he ended up getting to the floor and rallied for a couple days and ended back into the unit. This time he wasn't a candidate for ECMO, and then went back to the floor and went back again to the intensive care unit. So he'd been there about 40 days, and you know, it's very difficult for us as providers when we keep thinking, he's gonna make it this time. You know, we had a lot of people that made it, and we kept thinking he was gonna make it through this. He ended up not surviving, but the family actually had a beautiful presentation on CCO, and his daughter and his significant other called me that it was going to be on and talked about Abbott Northwestern and the care that we provided here. And this article also really talked about how COVID is real. We are seeing a lot of times in the hospital how many people don't believe it's real. And the message that they wanted to give out is what was happening in the hospitals, and Abbott Northwestern specifically, and then also to let the community up north in northern Minnesota, yes, this is really real. When should I consult a palliative medicine consult in the hospital? I think that a lot of times when colleagues need assistance with difficult cases is one thing that we often get called with. A lot of times in the hospital there are conditions that are difficult, meaning that people sometimes will have heart failure from substances or liver failure from substances, but how do we manage these things and be non-judgmental about it and caring? But also when people aren't doing well, how do we talk to them about that this might not be a possible survivable condition? I had this weekend case, a 50-year-old gentleman who came in with a cirrhosis, end-stage liver cirrhosis and Imelda 46. He's in liver failure and renal failure. When I see him at first, he's on dialysis to get his ammonia down. It was 350, and with all of this, his heart function was also decreased. He is not a liver transplant candidate related to recent drinking, and his wife says, please do everything, he's so young. He's delirious, he's barely maintaining his airway. He's thrashing on dialysis, making the run difficult because as his ammonia level's coming down, he was in a comatose state, but now he's starting to wake a little bit. The intensivist calls palliative medicine and says, please help. I need time to spend with family to talk about goals and what's realistic here. Prognosis with a MELD score greater than 40 is 1 to 3 months. But after 3 months without a liver transplant, it's quoted at about 0. That's a hard thing to swallow when you're talking to somebody and their loved one is 50 years old. We can't clear his sedation to keep him calm with his end-stage renal disease and liver function, so he's thrashing in the room. But if I'm going to give him medications, I'm worried that he's not going to breathe and that he'll never clear these medications. So he's also continuously bleeding, despite multiple clips placed to his duodenal bleeds yesterday, and we're using about 1 to 2 units of blood a day. So how do we help families in crisis with difficult prognoses like this? These are tough conversations. When I'm talking with somebody and they're absolutely in grief about losing someone young, the first thing I'm always doing is I'm asking permission when I'm talking. I sit down with them and say, I have hard things to talk about. I looked in the room, is there anyone else that should be here? And then I ask them permission. Is it okay if we talk about his prognosis together and what's happening? We confirmed his do not resuscitate status as he was on the brink of intubation. And they had been refusing the entire time, but when we start talking about what the actual prognosis is, it starts to make sense. We give him time to absorb information. They can see he's suffering and asked about his suffering and continuous restlessness. And we discuss then about why we're not giving medications for sedation to help him be comfortable or because of the consequences, and that we're getting into a wheel of, you know, if I give him something, he won't breathe. If I do X, Y, and Z. So sometimes what we have to do is start talking about why and when to do things. It's also about non-judgmental emotional support. When I have especially somebody who's got a family history of that it's felt that they've done it to themselves. They smoked, why didn't they quit? They should have not drank. You know, they were depressed. You know, why didn't they come in and do treatment at all? A lot of times it's to take that away. That's, you know, some people are sad and this doesn't happen. Some people drink, this doesn't happen. It's about just letting that go. That isn't part of the now. And really give them time to ask questions and cry and be in a safe space. Usually when you do those things, that you will end up with the time to really help them guide through something that's happened. Again, why and when? When you are intensivist and you've got 10 patients, or cardiologist and you've got 20 patients to round, this takes time. And this is a precious talk and a time in life to give people. So how do I give them the time that they deserve when we're having this goals of care conversation? I probably could have talked about every patient that I saw this weekend today. So who is appropriate for palliative care? So Alzheimer's, ALS, cancer, COPD, you know, any chronic long-acting diagnosis that'll be terminal eventually, but it's got a prolonged period of time. Who's not appropriate? Chronic pain without chronic illness or terminal illness, severe mental health, suicidal issues without a terminal diagnosis. Those people really need psychiatric care. Goals of care conversations that are short, that can be in a clinic or hospital, and it's not complex. When a patient and family are not clear that they are very clear, I want hospice, we don't need to be involved with that. Hospice then can handle that. And you know, a lot of times if we're only extubating, it's end of life, and we're only there for that. We don't need to be part of just that. If it's a process getting there, yes, but a lot of times if it's just to extubate someone, that's not for us. I guess the take-home message that is, if your loved one were dying, wouldn't you want a team of experts to support you holistically at the end of life? It's about talking through things like, I want money to donate, where do I give it? A lot of times I'm hearing, what do I do for a funeral? What do I do X, Y, and Z? I don't have a power of attorney. How do I find those kind of things? So it's really about talking about a lot more than just the here and now. It's about the whole process to support family. We also have a social worker and spiritual support. So we're a lot of times supporting young children in the hospital, materials for them, teenagers, how to talk with your families about end-of-life process. We also do spend time when it is time to merge with hospice and talking about that, if it is the time in the hospital or in the clinic. How do you consult? In the hospital, it's an IP palliative, and if you would like a clinic appointment, it's called ambulatory palliative in the notes. The hospice is at home or facilities, but palliative medicine is not only in the hospital, but we have clinics. There's one, I have a clinic in the Minneapolis Heart Institute building here, and then we also have clinics in the VPCI building, and we are now having more patients that we are having home palliative medicine where providers are going out to the home, which has been really successful for people who just really struggle between physical debility, etc., how ill they are to get into the clinic. All of us are going to die. The question should be, how do we want to live? What do we actually want to do with that time? Let's make sure with whatever time we have, we can try to achieve the realistic hopes one has. Any questions at all? That's what I have today.
Thank you, Leslie. That was powerful and enlightening. I appreciate that. Can you, just for my own ignorance, tell us a little bit about your department? How many individuals? How you cover
Yes.
the hospital, and you know, that kind of information that would be helpful.
Yes. So there's all Allina hospitals have palliative medicine teams. At Abbott Northwestern, our team consists of 3 physicians and 4 nurse practitioners. We have a social worker and we have a chaplain. And we also have support. If we're doing referrals out, I have a clinic in the MHI building. There's also one in the cardiac center. We're actually having one of our physicians is going to go full-time, and we're hiring a new physician, a full-time clinic position, because there's so many patients in that clinic. And so the social worker also is in the hospital, seeing a lot of times family members, talking with children, working with, you know, difficult situations, giving a lot of emotional support. And we have a chaplain that is really specialized in really tough end of life and also long-term diagnoses, patients with a lot of heavy symptom burden, to talk families through it, for us to offer a lot of support. We also connect a lot of times with home care to make sure that we can get more services into the home with home care as well.
And how about your coverage of the hospital?
Yep. So for myself, I have clinic 1 day a week in the MHI building, but then I'm there 4 days a week. But our team is 3 physicians in the hospital, and we have those 4 nurse practitioners in the hospital.
So weekends are covered?
Weekends are covered, yep. That's where I was this weekend. I had 2 12-hour days this weekend, yeah. So, yeah.
Can you comment a little bit about, you know, your role with our team, like especially with, let's say, LVAD patients?
Yes.
It's a little bit different. I would say it's a little bit more like bright.
Yes.
Just can you comment about like how you see those patients before implant and what your role is, and you know, like you sometimes discharge people from
Yes,
palliative care,
absolutely.
and can you just
Yes.
share that with everyone?
Yeah. So when we are consulted in the pre-op LVAD area, it's really talking about goals of care with family, talking about what this device looks like for the entire family process. It's not just about this person, but how it affects all the family members. And really talking about, again, a lot of work on getting things in order, making sure that you are set up in case something does happen. And really talking about, a lot of times what I find is people have been really thinking that they're going to pass for so long that it sometimes can be a difficult transition for people realizing, I'm going to live now and I'm going to have more time. So really trying to help navigate a kind of an opposite end of helping them to navigate that you are going to have more time. How do you do it? Let's get you out there. These devices, when we first put them in, we'd see people, we said, oh, you can't drive, you can't do this, you can't, and then I get all these pictures in the mail. Here I am on my tractor, I'm fishing, and you know, all the things we've not, but really it's about living. And so what we do for those people is really just kind of go through goals of care, and we follow them for a little bit after, but most of the people graduate. Most of the people we don't need to follow, because with an LVAD, the percentage of people having a great first year is, you know, 90+%. So really, that population is able to leave the hospital. They are also asking us now to start following. Actually, a lot of services recommend so us to be involved. We need a couple more people on our team to start doing all the services that are needed. But anyone with a trauma in the 80s, fall or something like that, they're asking us to really just come in and talk about goals of care and really to start assess what's going on in the home. It doesn't mean that I think this person's going to pass. It's about when you're falling in your 80s, you probably need services in the house. How do we get your family together? How do we get you more help so that you can live longer and be better? So those are some of the hospital consults that we're asked to see and that are recommended by guidelines. Again, all the advanced cancer patients with metastatic disease are asked. And a lot of times people with metastatic disease are living 5 years, 6 years, 7 years. But it's making sure you have those symptoms controlled And really, it's about spiritual health, mental health, and working with all of that in that time. So palliative medicine stretches a lot of times years. You know, some of the cases I'm talking about are shorter, but 2 years for somebody with congenital heart disease that was given, days to live, we've made a good chunk of progress there. And just by giving hope or giving ideas or really kind of pulling in services, what we're trying to do is give time. Mm-hmm.
Yes, we have a few online comments and questions. The first comment comes from Barb, who says, "Thank you very much. This was very informative and helpful." The next comment is anonymous, but they say, "Always grateful for your assistance with patients." But their question is, what words do you use to start the conversation with patients and families, and what are some helpful phrases?
Yes. When I'm coming into a room and I am going to see somebody who's got end-stage heart failure and ejection at 10%, and we know that they have more limited time. We don't know exactly what time that is. Usually the first thing I do is introduce myself, and I'm asking them, are there people that you should have in our conversation that would be helpful to listen? If any of you in this room have ever had a terrible diagnosis given to you, you can usually hear about the first 2 sentences. That's about it. It's really tough to hear beyond my heart is at 10%, EF is, I have cancer, I have something bad. It's hard to listen beyond there. So I usually try to get another person on the phone or in person. The next thing that I do is when I'm sitting down with them, I ask what they know. Tell me about what you know and understand, and tell me about you. Telling me about you really will get me a $1 million answer on what I'm going to be able to do for this person in the future. Meaning, how far can you walk? What can you do? Are you short of breath? Do you have chest pain? What are you able to do? And then I discuss what have you heard today or in this week about your disease and your prognosis. And then a lot of times I ask permission. The information I'm going to give you might be a little difficult. Can I have permission to talk to you about prognosis and what we can see in the future and how we can help you? I've never had a no, but if I go in and I don't ask this, can I have permission? Sometimes people will say, they just came in and talked to me about X, Y, and Z. If I have permission, then I've given the okay to start those conversations, and I don't get feedback like that.
Looks like we just have one more question come in. Thank you for your devotion and expertise. How do you, within this field, sustain yourself and keep going?
Mm-hmm.
Given that you're dealing with death continuously.
Yes. I think that this is probably the most rewarding work I've ever done. It is, for all the things that I've done, I feel I've really had a blessed career, being able to do the trials that I've had, the experience that I have received over the years. But this is a sacred time talking to people. It's hard news, but you're giving information that's touching somebody and their whole family all the way in. And to be able to do it gracefully and to be able to do it with an expertise and thoughtfulness and being able to really connect with families. Not that getting cards every day means that I've won the award, but when people spend time and send me packets, I probably get 1 or 2 a week of thank yous with notes of what this has meant to them or how this has helped. Even when I worked in surgery and I was with patients every day with LVADs from beginning to end, I didn't get lists like this because it's important for people. I find that if things go bad in the hospital, even if I have spent time and caring with families and gone through this with them, it erases a lot of the bad. It's somebody who said, I care about you, I'm listening to you, I'm spending this time with you, and that can take away a ton of hurt that's happened by no one's fault. It's just the illness alone, and it can make that experience from being really bad to being more positive for them.
Well, that was it for our online questions, so thank Thank you very much.
Yeah.